for our governance committee. I was told that there's no citizen wish to address to the committee today, so we're going to move to the approval of the minutes from December 5th, 2004. Does anybody have any comment or anything? Otherwise, I'd love to have a motion for approval.
Move to approve.
Second. All in favor? Signify aye. Any opposed? Motion passed. The next item is corporate governance update. Mr. Collins?
Yeah.
The floor is yours.
Let's see here. I was told there's a delay. There we go. And then I have to be patient with the clicker. That's not my strong suit.
Good on me? Okay. Well, Paul and I collaborated to get this presentation together for governance. We really wanted to provide an overview of how we manage organizational risk for the hospital district. We recognize that we bring information to the board through a lot of different avenues, and we don't always specifically categorize those activities as risk management. So we appreciate that it can be somewhat confusing when various functions are reporting out on similar topics, but this is really by design. We have an overlap of these functions, and that's the way that we cover off the holes in the cheese, so to speak, from a risk perspective. So when we talk about risk management, and just starting here, we're talking about ways in which we proactively manage the potential for adverse events to occur in any area of our operations, including, for instance, clinical, financial, technological, compliance, safety, and regulatory events. And generally speaking, there are 4 areas that are responsible for helping manage these various areas of risk. That is quality, information technology, corporate compliance, and enterprise risk management. The overarching risk strategy leverages these functions for proactive identification and trend monitoring across these domains. So you'll notice that when we illustrate regulatory alignment, patient safety, and organizational stability, we do that as overlapping circles, which is how a risk management strategy should work. For example, if you think about managing cybersecurity risks, for instance, you would think about the regulatory issues, internal and external threats, legal risk, and incident management. And so from a regulatory perspective, you have compliance assessing our systems and processes necessary to ensure adherence to laws and regulations, such as HIPAA and appropriate safeguards for that, which is through our breach prevention efforts. The internal and external threats, ERM is looking at those to determine the likelihood and potential damage and ensure that there are appropriate mitigation strategies in place. And then working with the cyber team, legal is working to help provide appropriate legal guidance to compliance, ERM team, and CIO to support and assess mitigation strategies and help direct management of cyber incidents. So getting back to our 4 overarching functional risk management areas, we want to talk about the various lanes of responsibility. Starting with quality, you see that there is proactive identification of risk through failure modes and effects analyses and internal review and analysis of any trends. They use dashboards to help monitor for potential trends and assess improvement. They do clinical event investigations and conduct root cause analyses and oversee promotion and adoption of best practices across the organization.
Sure. So next up is the information technology component, and anybody that's been a member of this committee for any time knows this has taken on a lot of focus in the governance committee of the board, as it should. So this is where cybersecurity and governance occurs. I think one of the questions that comes up fairly frequently is, what are we doing around AI? This is where AI use and threat management happens. Do we have an AI committee, things like that? Yes, we do. Do we have policies and procedures? Yes, we do. That is where this sort of thing comes on. This talks about cloud and on-prem. We have migration to Azure, which we'll talk about here in a little bit. Incident response and planning, our coordination with our MSSP, which is our outsourced cybersecurity function, would come up through this. And then it's a component piece, the technical safeguards function of ensuring HIPAA and healthcare regulatory compliance for patient information. This is where the EPIC technical safeguards come into place. From a corporate compliance standpoint, we're conducting ongoing comprehensive risk assessments covering federal and state laws that impact healthcare. That's the matrix I think you've seen a time or two where there's 60 or so some regulators that monitor healthcare in some place. And so we're looking at all of those regulators as part of our corporate compliance program. We're advising the CEO board, senior leaders on compliance, risk, strategy, operations, and our compliance program management. My function, as I think everybody here knows, reports directly to the CEO and the board of managers. Those are solid line reporting relationships. It's the same structure that Daphne has on the legal side of the house. So it's an independent function to ensure effective governance oversight. And then where there's overlaps, we're really collaborating with the chief legal officer on legal compliance issues. So something like I've talked about Stark, for instance, I would bring a concern to Daphne saying it bears the hallmark of a Stark violation or bears the hallmark of a kickback, and the ultimate determination is a legal determination that belongs to the legal department. So there needs to be a good cross-section of functions between the two of us.
And so moving back to enterprise risk management, we're kind of pointing out that isn't all of this really enterprise risk management, and it is. There are different focuses for the various functions, but that culminates with an overarching enterprise risk umbrella that's proactively managing risks and aligning with regulatory requirements, aligning with the various functions to make sure that there are appropriate processes in place to identify and help mitigate the risks that we're identifying through all of the various methods that we have for looking at risks that may impact the organization. We also, and I'll talk about this a little bit later when we get specifically into the enterprise risk section, but really working with third parties to have an overview of risks that are hitting our types of organizations from more globally across the nation.
So for my 3.5 coming up on 4 years here, we've really implemented a strategic approach to quantifying risk, what risk means. And so when I talk about this, it's not guesswork, right? When we call something a risk, it's data driven, and that's through any of the 4 domains. And then resources are allocated based on that quantified risk. So we do get, from time to time, the request, whether it's from senior leaders of the boards, to go look at something, and I'm happy to do that. It just gets slotted once the data supports it. So it's not, can you go look at X, Y, Z and ask for a jump, and we say how high. We do quantify it first, and then wherever it falls in that process, then it starts getting a look. And when we talk about what's it mean to get a look, that's where we want to do some mitigation activities, test controls, and look at interdependencies of risk. So we do use a ranking methodology here. So risk should be viewed in the context of this as a continuous improvement sort of cycle. We can't solve for every issue. That's not practical. We do have to have some risk tolerance in this organization and any organization. But when we talk about identification, assessment, monitoring, and reporting, it really is a continuous cycle. And so that is like what we bring to the governance committee every month when I bring a risk register and I talk about where we were previously and where we are now. It is a continuously evolving cycle, and it's that way across all of the domains. So leveraging technology, we have a lot of tools. I really wish from a risk standpoint across all these domains that there was a single bullet that we could use here to cover everything. It's just not practical. IT has a suite of tools, and quality has a suite of tools, corporate compliance has a suite of tools, and enterprise risk management has a suite of tools. Now, that doesn't mean that we can't all try to go ahead and live in the same system, which we're trying to do here in FY25 through RFP. As we look, especially on the quality side, is where the main driver of that will be the replacement or the next RFP for the clinical safety system. We'll have the ability to house more of these functions, so we're not living in 4 different systems. It would be really practically useful if we could all live in the same system. But then I still have to have software that overlays Epic to monitor privacy. And Dr. Badamosi needs tools from a quality standpoint, and Will needs tools from an IT standpoint. But when we come with those asks to the board, it's data-driven and risk quantified. It's not a tool for the sake of having a tool. There's an underlying reason why it's being asked for.
And similarly, from a non-technology perspective, we leverage our committees and work groups to pull all this work together. And as Colin mentioned, just like we are assessing the tools to see where we could get that centeredness, to take one of Will's words, we do the same thing with our committees. We're always assessing to see where we have the duplication, where we could pull these together and have one streamlined meeting. We do have different focuses, as Colin mentioned, so we're not always able to do that. But this is just a kind of an overview of how those committees and work groups work together to gather all this information from a risk management perspective.
Yeah, and there is some existing synergy between these four groups now, and I think it occurs at the appropriate level. So Miriam, who's the executive director back there, chairs a meeting of that level professional, where quality and IT and compliance and enterprise risk manager are already sitting together at the same table, discussing high priority risk for each domain. So we're not duplicating efforts. That's the last thing we want to do.
And making sure that everything that is handled outside of that forum is rolling up to that group.
Okay. So where does this come to the board through, and who's all responsible? So the quality stuff obviously goes to the quality committee of the board, and the other three will roll up here to the governance committee board, and then those minutes roll to the main board. So we have Will Showalter managing information technology. I have corporate compliance, Daphne enterprise risk management, and Dr. Badamosi is in charge of quality. So that is the sort of mapping to how it finds its way in front of the board. This one me still? So takeaways here is that it is a comprehensive strategy. So we do tend to touch each other's areas, but not in a duplication of work kind of stance. It really is to be proactively identifying risk that's across domains. We want collaboration amongst our teams. We're better when we're understanding what the risks are in each particular area. And then we also have skills to bring to bear in those areas that aren't necessarily controlled by me, or Daphne, or Will, or Dr. Badamosi. And then we do have advanced tools, and the tools are successfully managing and mitigating risk in this organization. We have shown a history, especially over the last 3 years, of being able to proactively identify problems, manage them, and sunset them before a regulator comes walking through our door. And that is really the true measure of success across all four domains, is are we able to avoid the regulator even coming to knock on the door? And if they do come and knock on the door because they're knocking on everybody's door, we've already managed it. The worst feeling I get is when it's on a risk register and we haven't gotten there and then the regulator shows up. That's the worst. So we really try to avoid that at all possible costs by having a really good fundamental way to assess what's a risk and how should it be prioritized across all domains. So we'll take any questions anybody has.
I have a question.
Yeah.
I don't know if it's from Daphne or Colin, but I bet I'm not the only person in the room that was not familiar with the term FMEA. So I looked it up. It's failure mode and effects analysis.
Correct. And
Do we actually use that?
I use the whole word.
I want to get FMEA. It's a military technique developed in the 40s. Do we actually use that in our risk program here?
We do, and Dr. Badamosi can tell you all about it.
Come on up, Dr. Badamosi. You do it a lot.
Welcome.
This is slide 11, by the way.
Yes, we actually do. We use failure mode effect analysis in a lot of situations. One of the areas we do is IC1. That's our infection prevention, proactively planning every year for the following year. How did we do the prior year? What are the areas of worries? What are the likelihood that this is going to happen? What are the likely consequences if it happens. So really, we score all of those, multiply it, and the effect of that is really highlighting areas we need to develop robust strategies for and how to mitigate those risks from happening. Also, suicide risk is one of those areas we also use FMEA for, looking at what we currently have in the organization. How do we assess both the patient, the environment, and our response, and scoring each of those? What is the worst case scenario when something goes wrong, and what is the likely impact, and how do we mitigate it, both in terms of the environment, our response to a suicidal patient, and any patient generally in terms of screening. So those are two big areas that we use FMEA.
Thank you for the examples.
Yeah. So,
Anyone have?
I was looking at the diagram on kind of the pyramid structure where quality is at the top and governance is at the bottom.
Mhm.
I guess my question is, when is it appropriate for the board to be involved in this process? When does it escalate to our level? And should we even be involved in levels kind of less than it rises to board level, such as areas of threat or things that we might need to intervene earlier in?
So we addressed this in the corporate compliance program. I think the appropriate level for the board is high level. So I think how it's phrased in the corporate compliance program is you're not expected to be actively ferreting out wrongdoing in the organization. That's what you have us for, right? So we are out there doing the investigations on your behalf, monitoring risk on your behalf, and reporting out on your behalf. Now that if you hear something in the context of a board meeting that's concerning, that's the point at which you should ask questions, and you can direct myself or Daphne to go back and gather more information.
And some other things like that, cybersecurity attacks.
Yeah. Does that answer?
Is that okay?
Yeah, I guess so. I think one of my concerns is what we don't.
Yeah.
You know, what's going on kind of under the structure that y'all are managing, and probably appropriately, but it's bubbling up. And are there times where the board should be involved before it reaches that high level? Trying to think, you know, you mentioned ransomware there, like, yeah, IT threats, we're getting regular threats. And while we're managing it, it's increasing, and we may need to be aware of that, you know?
Yeah, and I mean, I think that the way that we do that, I'll use quality as an example, like it's being viewed through many different lenses before it gets here, right? So you may end up hearing about something that actually did trip the radar from a litigation perspective, and then I'm reporting that out, which is part of the reason we're doing this, is because you're getting hit with your kind of risk management reports through various different avenues. From quality, you guys hear about our root cause analyses or some of our Sentinel events in closed session of the quality meeting, and that's where you're hearing about the more significant threats to the organization that we do need to make the board aware of and get insight around. So I do think you're getting it through different channels. One of the things I'm going to talk about, though, is we talked a lot about how, from an overarching enterprise risk perspective, we can kind of pull some of that so that you're getting more of a dashboard look at all of a heat map, so to speak, of all of the risks across the organization that we are managing, typically not at a level that you're going to get, specifically into the weeds around.
And I think it's one of the things that Dr. Badamosi has developed that I really love is that he's created dashboards. So it's kind of like we are able to see kind of the ongoing projects that are going on and what the system is doing to kind of improve these areas, whether they're areas that we do well in, sometimes that just needs maintenance, right? And sometimes it's areas where we actually do need to put resources behind and brain power behind. So I really appreciated what he's done in that area and wonder if it's appropriate in other areas in the governance part of the.
Yeah, and I will bring usually a top 5 into the, and you'll see it here in I think a slide or two. And that is what we prioritize to be the top risks. And then in the closed session, typically of the governance committee, I'll bring those issues that are the audits, but also issues that we need to talk about that I perceive are going to be a top 5, top 2, top 1. And so that is where that sort of comes through in the corporate compliance realm, and that would include IT and the other domains.
I think it's a great question. I mean, part of this whole conversation and how we started to look at it is because I was asking the same question. How do I know before it's really gotten bad? Because there's a lot that the team is working on constantly. I mean, I was driving Will crazy, like, oh, did we get hit with this? Is this a threat? And he's like, you got millions of these coming. And what we've done is assess, do we have the barriers in place? And we feel comfortable with that. So I think it's an excellent question. At which point does it escalate even to the CEO so that now there's an analysis to get to the board? And so I think this was a way to bring all conversation around risk together. To your point, I think the dashboards really do help give us, and it's what the teams use in order to indicate that there is risk that's now out of the ordinary. And then how does it now move up through the organization? So I think it's a fine balance, but a great question.
Margaret, are there specific triggers that would bring patient care issues to quality, specific individual patient issues?
Well, I think,
Sentinel events.
yeah,
will come.
sentinel events, and there's Daphne showed me kind of the algorithm that has to be met for it to be considered a sentinel event, and that's when it comes to us in quality, and we talk about it in the book session. So it has to reach a certain threshold. And so, yeah, I guess my big thing is there's, tons of, I'm sure y'all are dealing with stuff on an everyday basis that don't meet those thresholds, but there's patterns, right? And so that's one thing I would love to be able to identify is what are the patterns that we're seeing that maybe we need to intervene before it becomes a sentinel, right? So, and I think in quality, I feel like it's very obvious because there's a lot of research and data and what Dr. Badamosi's kind of put together to kind of help that. And in areas where I have less knowledge, like IT and, corporate compliance, I know you guys are working on that, but it'd be nice to kind of see what's going on under the surface.
You can jump to my enterprise risk management update if you'd like, just so that I can, because that's actually, again, the reason that Colin and I wanted to do the pre-education around how these various risk functions work together is that we are driving to culminating that so that you can see it all in one place. Because we heard Dr. Duncan that she mentioned asking, even knowing that we are bringing this information forward, it's just not labeled as, risk management efforts, and it's not all coming at the same time. And so, Colin and I are really partnering on working on that comprehensive tool, and it will be presented as an overarching enterprise risk management report out that does bring, and so some of it will be redundant, but it'll be kind of culminated so that you can see it all in one place, that you can kind of understand what is bubbling up. It has, the right lens from, Dr. Badamos, like you said, already has his dashboards, so what is he focusing on? What is Colin focusing on? What are we looking at from an overarching risk management perspective? What's coming out of the cyber space? And, you can see that all together. We are actively working with our cyber insurer to leverage tools to support our overall cyber risk management efforts and incident response. Will's team has already been in that through their IT security space, but this is leveraging, now this is a double check. How do we view this from an enterprise risk lens? Like what are threats that are potentially hitting our own system, and what are the threats that we know are out there? How have others responded to these big cyber incidents, bringing all that together. And then I have one other piece that doesn't relate to this discussion now that I'll come back to, but that will be what you'll see at our next report out from an enterprise risk management perspective.
I think that before we go to the next section, I have a question for you because I'm a little bit confused here a little bit, especially on page 12. We talk about AI use of threat management. Are we looking at just cybersecurity, firewall, from a risk compliance perspective of dealing with AI? Are we talking about beyond AI? Because the clinical side is, and the coding side and all that stuff is where I think some of our vendors start introducing AI into it. I don't think we may not address that, because without addressing it, business people But clinical people will rely on IT, and IT said, that's not my problem, that's your problem. So I'm worried about bias, I'm worried about error, I'm worried about transparency, I'm worried about accountability, because it controls the workflow and everything else behind it. And the computer said that, I'm done with it. So is that something that we should look at, or we out of scope here, and then we need to take a look at it differently?
All of those things are in scope, and I'll invite Will up if he would like to come, but for the AI specifically, rules of engagement, all of those things there's the clinical component because we're worried about the biases, right, that are inherent in AI products. But it's also the security component of layering that onto our network, especially if it's a beta thing, which we don't allow. And so there is, and I think it's modeled, if I'm not mistaken, Will, after the Texas rule that's about to come, which is pretty cumbersome and requires us to do a lot of things. We layered all of those in. The DOJ has specific new updated guidance for compliance programs about components that compliance should be looking at where AI is concerned or where emerging technology is concerned. And we put those in as well. And so it was 12 to 15 different areas that we will look at when AI, machine learning, emerging technology comes to the table in the form of a vendor bringing it to us. So
my concern is that, are we looking at it from the framework perspective, or are we looking at from the data perspective, right? Drive different decision making? Because you can put people in the slot and do a checklist. Yes, we have this, what people cover, but
So the answer is yes.
The line between business owner or clinical owner and IT kind of emerge together. Otherwise, nobody's talking to each other, but we're in the same room.
But to your point, we'll look at it in all three levels. We look at it from a standards. Are we acting the way we should? We look at it from a service level. Is the services that we're providing functional? And then we look at it from a logical level. And that logical level is it ethical, et cetera, but also a logical level, is it appropriate from a data use perspective?
Do we have enough staffing to do that?
We're working on that. We have the authorization, and we're working through those processes to bring on the appropriate staff. And I also remember that we brought to Finance Committee not too long ago the MSSP request. We're leveraging heavily a third party to be able to provide those services in the AI technology that's required.
Right, but those are to protect the infrastructure, right, of the organization. I'm more talking about the AI being used daily by clinician, by staff, by finance team, for coding, for compliance and all that stuff. And that may remove some of the layer of accountability, because you don't know who's doing what. And
so we want to make sure that we do know who's doing what. That's why we set up the process to be able to review what goes into production. How do we inventory what goes in production? Once it goes into production, how do we manage it from a security perspective as a tool? Then how do we manage it from a security perspective from a data? And then how often do we reevaluate the entire package?
We have an AI governance committee?
Yes, ma'am.
Okay, that's what I thought that we will put together. So any product that comes through that
yes,
utilizing AI that goes through.
Any product that
Partners there, the clinical partners and the IT people.
Any product that comes in goes through the data distribution review board analysis. It goes through an architectural analysis. It goes through a security review. And if required, then it goes through AI committee.
Is AI currently being used in any clinical form? Are the physicians using AI?
Wait, Dr. Kirby would like to see if it understands we're trying to.
Yes, we that we are in place. AI.
We do. We're leveraging AI embedded in, we're putting AI embedded directly into Epic, and that'll be available in September. So we are leveraging it. But it's also important to remember there's a fine line between what is AI and what is predictive analytics. And we've been using predictive analytics for a long time.
I'm guessing in the clinical use of it, it's kind of like ambient listening as well, right? So, I mean, at the end of the day, hopefully a physician or a provider is still overseeing and signing off what's in the computer. And I think that helps with what your concern is on the clinical level now, as far as like the financial office and like the other offices, they don't talk about it. But I feel like as far as like AI used in the clinical setting, a physician or provider level still has to be signing off on everything. It's not going to be AI is the ultimate determinant.
Because I'm fearful, because every organization goes through Lean Six Sigma and all that stuff, right? When you go through all that stuff, you have some inexperienced, unseasoned person questioning why you have to do that, but there's a price you pay for that experience from gray hair people telling you why you cannot do it this way until the machine or whatever is mature enough to be able to cover all that stuff.
You see that
That's
Will
why
is gray haired. He doesn't like it.
okay. Just want to make sure that we
Thank you, Dr.
we don't have
Duncan.
a Chinese wall.
Yeah. I still do that AI.
Let me have a couple follow-up questions. Are we going to be getting into ambient AI?
Yes, we will, particularly in the new facility. We have the vision of being fully ambient in a lot of areas.
I mean, I'm sure you're doing this, but a key to success in any technology, whether it's AI or any other form of technology, is constant collaboration with the end users,
Agreed.
the doctors, and nurses, and staff in the hospital, to make sure that they don't just get a tool presented to them and here it is, you're going to start using it. Hopefully before we cut the ribbon on whatever the new technology is, they've been involved with the selection and design and implementation.
So we have an RFP out at this point in time to look at IoT, the Internet of Things, cameras, wearables, et cetera. So we'll be doing some proof of concepts before we go live, but we're trying to set the standards for the new facilities. We're not going to be able to do a whole lot in this building because, quite frankly, we don't have the infrastructure to be able to support it, and the amount of money that would be needed to be put into that infrastructure are better served in the new facility. But we will be doing some small proof of concepts to validate and bring folks in, not just in the early stages of understanding and approving, but the stages of how does it work and the change management that's going to be required to scale it.
Are you saying we'll use it minimally in the current facilities, it'll be mainly in the new facilities?
I'm going to dance with that. Okay. So there are big projects that we're going to be doing facilities. The ambient scribe will probably spread it out to as much as the organization as possible. So it's really going to be based on the technology and the infrastructure that it's required.
Okay.
My only fear is being around IT for 4 decades is when we bring new AI technology in, are we going to be able to transform our workforce to make it more efficiently
We hope.
better?
Well, that is the goal.
Or we
That
can
is the
turn
goal.
around and see a 10,000 workforce.
No.
That is the goal and that is the vision. For too long, we've leveraged AI to find work. We've had great predictive analytics and great AI to be able to say this is the next thing we need to do. We have not leveraged ambient AI to remove work, and that is the whole point of looking at conversational EMRs, or in-room AI that not only can work with the EMR, but to define when status change, walk in, AI that can determine and document in the EMR when meds are given without having to speak.
Because obviously it's going to give us a lot of dashboard, a lot of analytics and all that stuff. Certain people will not be able to adapt to that. So there will be another layer of assistance trying to transcribe what that is. I've seen the worst of
And it'll be analogous to when we went from paper to computer.
The expertise and fast.
Yep.
To this point, we just can't.
Then you just double the force. It's harder.
Like regarding the end users, especially when it comes to the clinicians, they are really the ones that are driving a lot of this for us to get this up and getting going. So I think if people are actually using AI in their real lives and know what it can do and where it's being utilized, that they are really the ones that are driving this and helping us move forward. So it's a little bit different than it's been with other initiatives.
And is that through some sort of a formal committee structure or just?
Yeah, it's
people,
part of a committee
putting their
structure.
suggestion in the box?
No, it's part of the committee structure.
Do we
It's
have,
becoming standard of care. I mean, we have AI, my other job.
Yeah.
And
Most places do.
yeah, and physicians are notoriously slow adopters of tech changes, but I haven't seen anything with such enthusiasm as the ambient listening and the virtual scribes and because it documents so much better than we do out of our memory. It's a lot more accurate to kind of what happened. And it's very slick. I don't know what product y'all are looking at, but I'm assuming they're all similar. It's very slick that the end user can adapt it to the way they practice. So the more you use it, the smarter it becomes, the more it's specific to that.
What's the listening device used for these ambient?
Amazon, Alexa. No, I'm just kidding.
It actually can be leveraged.
Depending on how you set it up. But I believe there's different companies that might set it up different ways. But to that point exactly, it's something that, I mean, I'm sure Dr. Kirby agreed, but I really like it. I use it a lot in personal life, and I think it's extremely helpful. Obviously, there's different layers of safety to do for a healthcare organization, but it can augment your workforce. So the goal is it can make every individual more productive, more efficient, so you're actually not having to be tired. You can even, places that are actually doing it from the patient check-in. It helps to register patients better, it helps to capture their payers better, it helps to identify do they even qualify for these services much more efficiently and faster, collect payments better from a financial standpoint. Clinically, I think it makes you more efficient. The most basic thing is, can it get the information we're speaking on accurately in the chart? And it does that. And actually, we've played around, not with patients, just on each other. So you can actually, they have a bunch of apps now you can try, and they're very good. It's almost incredible how well structured they make your note. It's almost better than what we do. It takes seconds compared to doing all that and taking 20, 30 minutes later on.
Well, those apps designed for individual practitioners or for a
A
hospital?
lot of outpatient people are using it already. So they are doing it. Most are like HIPAA compliant and safe. Obviously, we're not using it in any form at JPS currently, but we play around with it in the office, just seeing how it works. But a lot of people we know outside are doing it. I have a radiologist friend in South Carolina. They use it in their radiology practice, but each person then has to go and sign off on the report that the AI created from bringing an image, essentially. So it still has some level of safety and balance after.
If you're using one of these apps individually in your own practice, how do you keep it HIPAA compliant and get a BAA from the technology provider?
I believe a lot of them get certified as that.
Well, nothing is saved. Nothing is saved.
Yeah.
It's all in this lab.
Yes, we would get a BAA, like, absolutely, 100%.
And if it's
Guaranteed,
certified by
without
FDA.
question.
My question is, are we prepared from a ethical and legal to defend ourselves? Because you recorded a lot of stuff. And when discoveries, those things have to come out. And if it's privacy concern, but discussion with the patient or discussion with some treatment and stuff like that between peer-to-peer, will that get more people into the legal problem when it's come to malpractice and all that stuff? Have we addressed that side of it as we bring it in or start looking at it?
We are addressing it, and the state of Texas is very focused on that.
I'm sorry, I couldn't hear you.
I said we are looking at it. We are trying to address it, and the state of Texas is very focused on that specific issue. It will change how we do consents.
Mhm.
Yeah, well, to your point, the patient is also part of that.
Yes, discussion. Mhm. I think that's more scarier for me than anything else as we look at it. But
There's a lot of groups working on standards around health organizations using
Mhm.
AI.
Mhm.
That's one of the podcasts with the UT school that does the healthcare MBA.
Mhm.
One of the groups there, he's actually the chair of the committee for ANSI, and that's like the international sort of standard.
Yeah.
And so they're creating AI standards. A lot of it is when your organization is getting a product that you have clear visibility of what AI they do. So to avoid biases, that they're not entering their own bias in anything that they've given you product-wise. So some places won't allow you to see their data and what database they built their AI technology on. And you want that transparency when you bring that into an organization so you know where your data came from, what population they use, what that data they use. There weren't any biases already built into it, essentially.
Which I always get stuck in the detail and talk about compliance and legal issues, but I think one of the great takeaways that we're ignoring or not discussing is the women patients.
Yes.
I think you'd be shocked how much time we spend charting, documenting regulatory science needs to know. And if I can have that done when I walk out of the patient room, that's more time I can talk to a patient at work, or I can be with a patient getting procedure. So this would really bring the physician back to the bedside. And from a board perspective, that's what we want to emphasize and roll out is how their patients will benefit from this. Secondly, you have physicians who are going to love coming to work, and they're going to leave without charts to finish, and your physicians will be more engaged and more available. So it's a win, primarily for patients, but also.
And nursing too will be.
Right, no, the nursing.
They spend so much time.
Yes.
And behavioral health, we've been focused on that area as
It's
well.
well worried because there's more lawyer out there.
Yes.
And, okay, go ahead, next one.
I mean, and also, I mean, and again, I'm just speaking from my own experience with it, and I'm assuming that most healthcare ambient listening platforms are similar to the ones I use. You know, we have transparency in documentation now, and so patients are able to see their charts, and so they know exactly what we document. And so whether we're using AI or we are handwriting it from our memories, they get to see it. And so I think there's a level of safety in that too, and that's why physicians are actually looking at this stuff before they're signing the name off of it, and not just relying on what AI is documenting, because it is open for patients to see.
I think that part, I think is a plus for patient care. The other part behind the scenes, what I was worried about, because you take accountability out, you take transparency, and then there's a variety of stuff that AI built in that take away the quality assurance side of it. So unless you have somebody behind the scene who experienced doing deployment and integration and also ongoing maintenance, any mistake there, you take away the people that understand. And that's where the problem comes in. And so those are some of the things that I want to focus on, the infrastructure of it, not the use of it. Technology is always good.
No, you're right. And every time there's a tech update, there's always glitches that we all have to work through. So yes, we're very aware of those. Yeah, for sure. You get like a million emails per turn.
Yes, sure.
All right. Yep.
That's number 5. No, I'm just kidding.
Page 11, what is just culture? Just culture.
Just culture is really a principle of assigning responsibility when you have a safety event and ensuring that nobody is above the law, so to speak, in the hospital. First, that everybody feels comfortable to report, regardless of the situation, regardless of who is involved. And it really tries to put some objectivity in the way safety events are analyzed. If a safety event happened, the first principle of just culture is, would a reasonable provider or nurse or staff member with adequate training in the same situation have the same or similar outcome? If they do, then that will mean it's a system issue, not a provider issue. The second principle will be, was the provider or the nurse or the team member impaired, right? Was it a willful act? Is there a governing hospital policy that is established and training process? So all of this will be looked at to make a key determination. Was this a deliberate act, right? Was this a system issue? Was this a training issue? Was this a professionalism issue? So applying this principle to every safety event ensures that an individual does not get blamed for a system issue. If it's a system issue, we need to work at it and hardwire as well as offer training. If it's an individual issue, there is a pathway to analyze the event. Was it lack of training? Was it intentional? And were they impaired during the process of that decision making? So all of these is really what is referred to as just culture.
When you have a just culture, the team feels as if you're fair when you go to
Correct.
assess what has occurred. But there's an objective way in which you're assessing it. You're not just going straight for blaming the person or the process, but you actually a fair way of assessing.
And that's how we deal with incidents.
Yes, sir.
Yeah.
Yes.
Thanks, Dr. Badamasi. All right, we'll push into corporate compliance internal audit. I threw this slide in here just by way of reminder because I don't put it up all that often, but the work that we do, even in corporate compliance and audits, ties back always to our strategic priorities in the organization, and I listed a number of ways why and how that is. The space I play in primarily is the financial sustainability thing, which you will see here in a little bit, and that's fraud, waste, and abuse, primarily in the coding environment. But I do, and my team does, work in all three of these particular areas with audits. So I bring back, as I always do, where we left off. So Will did some presentations and did our IT roadmap, which contains our 3 projects, which we'll see in the next one. Inpatient short stays, the audit has been completed. The error rate was under the acceptable limit, and so no risk. And then MSDRGs, the more than 96 hours on mechanical ventilation, that audit has also been completed, also below the standardized error rate that we would accept, and so that has also been mitigated. So those were, by way of reminder, part of a Medicare fraud report that I received. That's how they wound up on our risk register and got prioritized and got put in the queue for audit. And so that took a few months to do, but we are done with both of those. This is the current risk register. So on the IT side, we're looking at implementations. And this is really a modernization effort that will, across the board, mitigate noncompliance in a number of different areas. So we're talking about Azure, that's our cloud migration, our MSSP, that's our outsourced cybersecurity function, and then the Infor implementation as well. Just as a tag along to this, we do have an RFP out right now for my team to have a separate auditor to monitor the MSSP vendor. And so it's an extra layer, as Blake pointed out, which I think was a good corollary. It's like having your auditor for the construction. It's just a good idea. We don't possess the expertise internally right now, nor do any of our auditors. That's why we outsourced all of IT security to begin with, but we do need a way to monitor that they are doing an effective job on our behalf, and so that's out there right now. On the coding, billing, fraud, waste, and abuse side, we're looking at leveling forms right now. So there are a number of templates built into Epic that assist a physician with how to level their charts 1 through 5. We feel like we've seen some anomalies in some of those where it's getting overcoded. And so we're going to look at all of them and assess from an audit standpoint, are these things leveling effectively? I know we use them in the ED, we use them in some other places. And so we're going to look at those. 99214 is an E&M code. This is also a file level code. We've seen some indication that we're a little bit high, certain of our physicians comparative to peers. It does not mean there's a compliance problem. It does not mean it's anything other than they're a little bit out of step with their peer in certain areas, and so we'll look at it. Our patient population is slightly more complex than others, and so that may make sense. And it could be this is nothing, and that may be where we wind up. But for now, it's on there. Physician compensation I will talk about in closed session, and the copay collectibles is not, I will also talk about in closed session.
Do you use a just culture or somebody upcoding?
No, we do a payback.
We do a lot.
We do a payback. And that's it for, you had a second part of your enterprise risk management?
So we pretty much gave the enterprise risk update for this month. There's going to be a more complete report out for the next time where we actually pull all those areas together. Enterprise risk has some more focused work going on around financial risks, workplace violence prevention, and cybersecurity risks. But I did want to mention that next month is Workplace Violence Prevention Month. So our workplace violence manager has coordinated with various leaders across the network to host learning sessions for our teams, including in our outpatient settings. And those are designed to really increase awareness and assess areas of concern.
And then, we're going to go to closed session, closed meeting, and we're going to go to closed session. adjourned. Thank you.